A very good evening to one and all present here. I'm Dr. Borahae, representing Mic Drop Medics. Today we are going to master one of the most frequently performed, yet arguably the most frequently botched clinical skills in medicine: blood pressure examination. We are moving away from the mindless pump and dump routine and diving into a true bedside clinical approach. Let's drop the mic on standard error-prone vitals. Before we touch a patient, let's ground ourselves in the physics of the vasculature. Blood pressure is simply the lateral pressure exerted by a flowing column of blood against our arterial walls. Mathematically, it's a tight dance between cardiac output and peripheral resistance. Blood pressure equals cardiac output into peripheral resistance. We track four core numbers. First, systolic blood pressure, SBP. The peak pressure during ventricular contraction, which is normally 120 plus minus 20 millimeters mercury. Second, diastolic blood pressure, DBP. The resting baseline pressure just before the next beat, which is normally 60 to 90 millimeters mercury. Then we have pulse pressure, PP. The difference between the two, pulse pressure is equal systolic blood pressure minus diastolic blood pressure, which means PP equals SBP minus DBP, which normally sits at 40 millimeters mercury. And finally, mean arterial pressure, MAP, the true driving force of tissue perfusion, calculated as diastolic blood pressure plus 1/3 of pulse pressure, which means DBP plus 1/3 of PP, which normally sits around 95 millimeters mercury. Now, how do we hear these pressures manually? We listen for the Korotkov sounds. Discovered back in 1905 by Russian physician Dr. Nikolai Korotkov, these are the rhythmic tapping noises we hear through our stethoscopes. It's important to remember that you aren't listening to the heart valve closure here. You're listening to a fluid dynamics transition. When a cuff is fully inflated, the artery is collapsed. Complete silence. As you release the pressure, the artery goes from a completely collapsed to partially open, creating massive turbulence. That turbulent blood hitting the arterial walls is exactly what creates the sounds we are about to break down. As we deflate that cuff, the sounds progress through 5 distinct phases. Phase 1. The first appearance of faint, clear, rhythmic tapping sounds. The moment you hear this, you have hit the systolic blood pressure. Phase 2. The sounds soften into a swishing or murmuring quality as the artery opens up a bit more, allowing increased blood flow. Phase 3. Suddenly, things get crisp, sharp, and much louder as a sudden rush of blood forces the vessel open. Phase 4. The sounds become abruptly muffled, soft, and blowing. Keep an eye on this phase. It can be used to estimate diastolic pressure in special populations like pregnant women or children. Phase 5. Total silence. The sounds disappear completely because normal silent laminar blood flow has resumed. This absolute disappearance marks our diastolic blood pressure. To understand this better and to visualize this clearly, let's map the pressure to what your ears actually perceive with the help of an example. At 120 millimeters mercury, you get the first third of phase 1. By 110 millimeters mercury, it transitions to a blowing noise in phase 2. At 100 millimeters mercury, it settles into the softer third of phase 3. Around 90 millimeters mercury, phase 4 hits with a distinct muffling sound. And finally, at 80 millimeters mercury, the sound completely vanishes in phase 5. The core clinical rule to imprint on your mind: phase 1 is your top number and phase 5 is your bottom number. So why are we being so pedantic about these phases? Because precision matters in medicine. The top number represents maximum ventricular effort. The bottom number represents minimum arterial resistance at rest. But here is a major clinical trap for your wards and your viva exams: the auscultatory gap. In elderly patients or those with severe hypertension, there can be a temporary mysterious disappearance of sounds between phase 1 and phase 2. If you don't inflate the cuff high enough, you will stumble into this gap and completely underestimate the patient's true systolic pressure. Let's look at how to avoid that. Accurate measurement begins long before you put on your stethoscope. Step 1 is all about patient preparation, and it's where most routine checks fail. The patient must rest comfortably for at least 5 minutes. Their back must be supported, feet flat on the floor, and legs uncrossed. They need to have avoided caffeine, heavy exercise, and smoking for at least 30 minutes. Always ask them to empty their bladder beforehand. A full bladder can falsely elevate systolic blood pressure by several millimeters. Finally, absolute silence. Neither the patient nor the observer should talk during their measurement. Take a look at this clinical layout. Notice the patient's posture. Her feet are planted flat, legs are completely uncrossed, and her back is firmly against the chair. The doctor isn't chatting, and the patient isn't scrolling through her phone or talking. This is the pristine state required for a true baseline reading. Step 2 is about equipment and engineering. First, ensure you're using a clinically validated BP device. Second, the arm must be bare and supported at heart level. Specifically, the middle of the cuff needs to align precisely with the level of the right atrium. Now let's talk cuff sizing, because one size does not fit all. The bladder width should be roughly 40% of the arm circumference, and the bladder length should wrap around 80 to 100% of the arm. Position the lower edge of the cuff 2 to 3 centimeters above the antecubital fossa and center the bladder directly over the brachial artery. This illustration perfectly visualizes the alignment. Look at how the arm is resting on the table so that the cuff lines up horizontally with the right atrium. If the arm is too low, gravity will give you a falsely high reading. If it's too high, you will get a falsely low reading. Notice also the selection of small, medium, or large cuffs. Putting a standard adult cuff on a highly muscular or obese arm is a guaranteed recipe for a false hypertension reading. Now we execute. Step 3. Take the measurements. On a patient's first visit, you must record the BP in both arms. If there is a discrepancy, use the arm with the higher reading for all future measurements. Always take repeat readings 1 to 2 minutes apart to ensure consistency. When inflating, go 30 millimeters above the point where the radial pulse disappears. Then deflate slowly, about 2 millimeters per second. Catch the first Korotkov sound for systolic blood pressure and the disappearance for diastolic blood pressure. If the sounds stubbornly persist all the way down to 0 millimeters mercury, fall back on phase 4, the muffling point, to document your diastolic blood pressure. Here is our complete workflow roadmap. It takes us seamlessly from the initial 2-arm screening through the controlled deflation rate of 2 millimeters mercury per second, all the way to identifying the true phase 1 and phase 5 sounds. This graphic highlights exactly what you are listening for: that transition from a clear tap to a swish, to a loud thud, to a muffle, and finally to perfect clarity. Record it clearly as systolic over diastolic. A measurement unrecorded or poorly recorded is useless to the clinical team. Step 4 demands proper documentation. Don't just scribble a pair of numbers on a chart. You must document the exact BP reading, which specific arm was used, the precise position of the patient, whether they were supine, sitting, or standing, and critically the exact time they last took any antihypertensive medication. A reading of 140/90 sitting down before medication means completely different than 140/90 standing up 2 hours after taking a beta blocker. Look at this exemplary chart entry. It clearly notes 120/80 millimeters mercury, left arm, patient sitting, and time of last antihypertensive medication 8 a.m. today. This gives any physician looking at the chart the full clinical context required to make high-stakes adjustment decisions for the patient's treatment regimen. Step 5 introduces the law of averages. Diagnosing a patient based on a single isolated high reading is bad clinical practice. Guidelines dictate that we use the average of 2 or more readings taken on 2 or more separate occasions. However, what if the rhythm itself is inherently chaotic? In cases of atrial fibrillation, a single snapshot reading is completely meaningless. You must obtain at least 3 distinct readings and average them out mathematically to find out the true baseline. The final step in our bedside clinical approach is patient empowerment. Step 6. Inform the patient. Never leave the patient in the dark or give a vague like, "Oh, it looks fine." Provide their systolic and diastolic numbers both verbally and in writing. Explain exactly what those numbers mean and pair it with actionable healthy lifestyle modifications and clear follow-up advice. A patient who understands their numbers is a patient who complies with their treatment. As this infographic shows, giving the patient a physical or digital record, complete with the date, time, and explicit follow-up instructions, bridges the gap between clinical examination and long-term therapeutic success. It turns a routine vital sign check into an active intervention. Let's quickly review our adult cuff sizing parameters. For an arm circumference of 27 to 34 centimeters, a standard adult cuff is perfect. If the arm measures 35 to 44 centimeters, you must step up to a large adult cuff. And for severe obesity or massive muscular builds measuring 45 to 52 centimeters, you require an adult thigh cuff wrapped around the upper arm. Memorize these ranges because using a cuff that is too small will overestimate blood pressure, causing you to diagnose phantom hypertension. Let's zero in on a classic MD level Viva favorite, measuring blood pressure in atrial fibrillation. This is uniquely challenging because atrial fibrillation presents an irregularly irregular heart rhythm. Because the rhythm is completely chaotic, the stroke volume and the volume of blood pumped changes with every single heartbeat. This creates a massive beat-to-beat variability. Standard automated monitors get completely confused by this randomness, which is why they frequently spit out error codes or widely inaccurate numbers. To tackle this, British and European hypertension guidelines emphasize a return to manual measurement and strict adherence to the law of averages. In any clinical or exam setting, when a patient has atrial fibrillation, you must push the automated oscillometric device aside and grab your manual sphygmomanometer, whether mercury or aneroid. Manual measurement remains the absolute gold standard here. So the question is why? Because a trained human ear can listen to the actual Korotkov sounds across multiple varying beats and mentally average out that chaotic turbulence. No basic machine algorithm can match that clinical judgment. The manual technique in atrial fibrillation requires rigorous precision. We start with the standard preparation, 5 minutes of rest, perfect cuff sizing, and the arm supported at the heart level. But here is the critical variation. You must determine the estimated systolic pressure by palpation first. Keep your fingers on the radial pulse, inflate the cuff until the pulse vanishes, and then prepare to inflate the cuff 20 to 30 millimeters above the estimated level for your auscultation phase. Now write this down in gold ink. The golden rule of deflation in atrial fibrillation. Normally, you can get away with deflating a cuff at 2 to 3 millimeters mercury per second. With atrial fibrillation, you must deflate it even slower, around 2 millimeters mercury per second, or effectively 2 millimeters mercury per heartbeat. Think about the physiology here. Because the beats are irregular and skipped, if you deflate the cuff too quickly, you will drop right past a true systolic beat during a long pause and completely miss the true systolic number. When recording, listen carefully. Record the systolic blood pressure at the first Korotkov sound that is heard consistently. Don't just catch one isolated random loud beat. Wait for the consistent tapping pattern to emerge. For the diastolic blood pressure, listen for the absolute disappearance of the Korotkov sounds marking phase 5. If these sounds continue to echo all the way down, you default to the phase 4 muffling point. Let's visualize this 4-step sequence as a summary. Step 1. Pristine preparation. Step 2. Palpating to estimate the inflation ceiling. Step 3. The key step. Slow deflation at 2 millimeters mercury per second to account for the erratic rhythm. And step 4. Pinpointing systolic blood pressure at the first consistent sound and diastolic blood pressure at phase 5. Remember, slow cuff deflation is your absolute shield against measurement errors in atrial fibrillation. Because blood pressure naturally fluctuates widely from minute to minute in an AFib patient, a single snapshot reading is practically useless. It's a random lottery ticket. To conquer this, you must take at least 3 separate manual readings, ensuring you space them 1 to 2 minutes apart. Then calculate the mathematical average of those 3 sessions. That average is the only number you can ethically and clinically trust to guide your management. Let's look at the math in action for an atrial fibrillation patient. Reading 1 gives us 142 over 86. Reading 2 drops to 136 over 82. Reading 3 ticks back up to 140 over 84. If you only took reading 1, you might over-medicate. If you only took reading 2, you might under-medicate. By calculating the mathematical average, we arrive at a highly reliable true blood pressure of 139 over 84 millimeters mercury. So what I'm trying to say is that if the readings are 142 over 86, 136 over 82 and 140 over 84, we don't just pick the lowest or the highest to fit the narrative. We combine them, average them and confidently record 139 over 84 millimeters mercury. This eliminates the noise of beat-to-beat variability and uncovers the patient's true systemic pressure. Now, what happens when the patient goes home? They can't take a manual reading themselves, and we know standard machines struggle. If home tracking is vital, we must give them 3 strict rules. First, use an upper arm cuff only. Wrist or finger monitors are wildly inaccurate in healthy patients, and they are completely disastrous in atrial fibrillation. Second, they must purchase a specialized AFib validated device such as specific models from Omron or Microlife that feature dedicated irregular heartbeat algorithms. Third, have them bring their machine to the clinic. We can run a manual test on one arm and check it against their digital machine to cross-verify its real-world accuracy. Let's consolidate this. into a crisp clinical pearl for your rounds and exam defense. When an examiner asks you how to assess blood pressure in an AFib patient, your answer should be immediate. Sir, I will use the manual auscultatory method. Employ an exceptionally slow cuff deflation rate of 2 mm mercury per second. Take at least 3 distinct readings and average the results to eliminate beat-to-beat variability. That response shows true physiological understanding. Let's do a deep dive into the phenomenon, the auscultatory gap. By definition, it is a temporary disappearance of Korotkov sounds during cuff deflation, followed by their reappearance at a lower pressure. If you fall into this trap, the consequences are dual and disastrous. You will drastically underestimate the true systolic BP, and you can overestimate the diastolic BP. So who is at risk? We see this predominantly in elderly hypertensive patients, individuals with advanced carotid atherosclerosis, and anyone with severely increased arterial stiffness. So the question is, how do we defeat this hidden clinical trap? The absolute gold standard is the palpatory auscultatory method. This means you must estimate the systolic pressure by touch before you even put a stethoscope to the patient's arm. If you skip the palpation step, you are flying blind. So let's look at exactly how to perform this dual-step approach properly. Step 1. Estimate systolic pressure by touch. Wrap the cuff properly around the bare upper arm. Locate the radial pulse at the wrist and keep your fingers firmly on it. Now, inflate the cuff steadily. Note the exact pressure on the manometer where the radial pulse completely vanishes under your fingers. Once you find that point, deflate the cuff completely and let the patient's arm rest for 30 to 60 seconds. You now have your true tactile baseline. Step 2. Listen with your stethoscope. Place the diaphragm or bell over the brachial artery at the antecubital fossa. Now, inflate the cuff to 20 to 30 mm mercury above the pressure where the radial pulse disappeared during step 1. By doing this, you guarantee that you inflate the cuff higher than any potential hidden auscultatory gap. Now deflate the cuff slowly at 2 to 3 mm mercury per second and listen intently for the true phase 1 and phase 5 points. Let's look at a concrete, real-world example of how dangerous skipping this can be. Imagine a patient with true blood pressure of 200 over 90 mm mercury who has a massive auscultatory gap sitting right between 170 mm mercury and 140 mm mercury. If you skip palpation, you might blindly inflate the cuff to 160 mm mercury, thinking that's high enough. When you open the valve, you hear absolutely nothing at first because you are sitting right in the middle of the silent gap. The sounds finally appear at 140 mm mercury. And you record the blood pressure as 140 over 90 mm mercury. So what is the terrifying result? You just missed a dangerously high stage 3 hypertensive crisis of 200 mm mercury by a massive 60 mm mercury margin. Now, let's look at the right way. You use the palpation step first. So as you inflate, you feel the radial pulse vanish at exactly 200 mm mercury. So yes, you know their systolic pressure is up there. Now you safely and intentionally inflate the cuff all the way to 220 or 230 mm mercury. As you deflate, your stethoscope catches the true first phase 1 sound at 200 mm mercury. Then you watch the dial as the sounds go completely silent at 170 mm mercury and reappear out of nowhere at 140 mm mercury, and then finally vanish for good at 90 mm mercury. So what is the result? You get a perfectly accurate reading of 200 over 90 mm mercury, and you successfully document a 30 mm mercury auscultatory gap. So you saved the patient and you aced your clinical exam. The absolute key takeaway here is that if you ever hear Korotkov sounds instantly vanish and then return a few moments later as you deflate the cuff, you have crossed an auscultatory gap. Do not ignore it and do not think your stethoscope slipped. Always explicitly document both the true blood pressure numbers and the exact presence and span of the gap in the patient's medical chart. So to wrap it up, blood pressure measurement isn't a mindless automated task. It is a refined clinical art that requires deep physiological understanding, especially when facing challenges like atrial fibrillation or an auscultatory gap. By mastering these bedside techniques, we ensure better data, better diagnosis, and ultimately better care for our patients. Thank you very much for your time and attention.